Welcome to Pathology Central Key Concepts. The topic of this video is osteoarthritis versus rheumatoid arthritis, a head-to-head comparison of two major causes of joint pain. Therefore, I'm going to focus only on these two entities with a compare and contrast of the clinical and pathophysiologic findings. I'm going to begin with osteoarthritis, which is also known as degenerative joint disease, or simply DJD. Osteoarthritis is due to cartilage degeneration due to mechanical and structural issues that leads to the structural and functional failure of synovial joints. However, inflammation is a secondary contributor to these pathologic findings. Primary osteoarthritis is associated with aging, and we typically will see it in individuals over the age of 50, and about 40% of people over 70 will have some form of osteoarthritis. Secondary osteoarthritis is osteoarthritis that occurs in the context of some sort of other joint issue, such as a joint deformity, diabetes, hemochromatosis, and marked obesity, and it tends to occur in younger patients. Now, clinically, osteoarthritis will present with deep, achy pain that worsens with use. There's morning stiffness that does resolve with activity. Crepitus, which is a crunchy sound and feeling and movement of the joint, can also be seen, as well as decreased range of motion. Osteoarthritis is typically oligoarticular, which means it affects multiple joints, but a few, and typically the joints that are most affected by weight impact, so hips, knees, lower lumbar, and cervical vertebrae, but also the proximal and distal interphalangeal joints of the fingers and the first tarsometatarsal joint of the feet. One thing you can see clinically is something that's referred to as a Heberden nodule, and this is when we get osteophytes that are quite prominent at the distal interphalangeal joint, and we'll talk more about osteophytes in a moment. So what is the pathogenesis? So we have some sort of articular cartilage degeneration, and this plus disordered repair leads to osteoarthritis. So biomechanical stress will lead to chondrocyte injury. Now, most chondrocytes are sitting there quiescent in the articular cartilage, but with biomechanical stress and injury, they will begin to proliferate and to elaborate cytokines. Now, proteoglycan degradation does occur typically throughout life, but we also have proteoglycan synthesis. When you have significant biomechanical stress, proteoglycan degradation is going to outpace synthesis, leading you further along the path to osteoarthritis. And furthermore, as part of the inflammatory component of osteoarthritis, matrix metalloproteinases will degrade the type 2 collagen network, causing further injury to the collagen and the cartilage. Now, cytokines such as transforming growth factor beta will elicit matrix metalloproteinases. We also know that prostaglandins, proteases, and nitric oxide are all involved in the pathogenesis of osteoarthritis. But before you start memorizing these, please take a look at this list here, which comes from UpToDate, and recognize that there is no point in memorizing all the different cytokines involved in this inflammatory reaction. These are just the ones that are the major ones, and even for these, their roles are not completely understood. We believe that bone morphogenic protein, BMP, plus TGF-beta are involved in osteophyte formation, but the roles of some of these others are not as clearly understood. So let's look at a cartoon from Robbins and Kumar Basic Pathology, 11th edition, to get an image of what I just gave you in words. So here we have our healthy joint, but then we begin to get some sort of biomechanical injury, and this can be on some genetic background that predisposes to changes in ability to repair in response to injury. We see here we have our synovium, type 2 collagen, you can appreciate it as these light blue lines, and then we have proteoglycans are these squiggly light blue ones here. Now, as we get this injury, ordinarily we would have repair, but as we get continued injury, we're going to move on to early osteoarthritis. Now, as we get breakdown of collagen and of the proteoglycans, we're going to get these fissures that form in the surface of the cartilage. This is referred to as fibrillation. The injury is going to cause chondrocytes to proliferate, and part of that proliferation is going to be elaboration of bone morphogenic protein, which works in an autocrine fashion to stimulate more chondrocyte proliferation. And what we'll see typically will be these little nests of chondrocytes. The injured chondrocytes will also begin elaborating a number of factors such as PGE2, nitric oxide, and TNF, which will contribute to the inflammatory milieu that we see in osteoarthritis. The synovium can secrete TGF-beta, which will cause chondrocytes to release matrix metalloproteinases, which will lead to collagen degradation as well as proteoglycan degradation. And this TGF-beta is going to feed in here. We have an incipient osteophyte forming here. And then with progression, what we can see is, first of all, our osteophyte is much larger. But these little fragments here where we have these fissures, these can pop off to form cartilaginous loose bodies, also known as joint mice. They can ossify in the joint capsule within the space here. We can get chondrocyte dropout due to apoptosis, and as these bits of cartilage are sent forth into the joint space, we have exposure of the subchondral bone. This is going to cause abnormal mechanical stress, which can lead to sclerosis, and we can also get small fractures. The pressure of fluid here in the joint can enter that fracture, causing a subchondral cyst. All right, so let's talk about our morphologic findings. We've just covered some of them here. So I'm going to include radiology as part of morphology because it's something we use our eyes to see. And one of the classic features will be joint space narrowing. We can also see subchondral sclerosis, as I mentioned, subchondral cysts, and osteophytes. Now, grossly, if we look at a joint that's been removed for arthroplasty, we'll see that the cartilage may be granular and soft. And because this occurs because we have breakdown of our collagen and our proteoglycans, it's going to absorb some more water. And then as these pieces are shed into the joint capsule, we get our cartilaginous loose bodies or joint mice. And that exposed subchondral bone will rub against the other area of subchondral bone, and this can cause burnishing of that surface so that it looks like a cue ball from a pool game. This is referred to as eburnation. It's completely smooth, and this causes additional pressure because you have lost the shock absorber of that articular cartilage. As I mentioned, we get sclerosis and fractures of the underlying bone, which can lead to our subchondral cysts, and we get these bony outgrowths, osteophytes. Now, we don't typically use histology or microscopy to make a diagnosis of degenerative joint disease. It's a clinical radiographic diagnosis, but we will see these specimens as part of the arthroplasty process, and then we'll recognize there's fibrillated cartilage and synovium that's mildly edematous with only minimal inflammation, although inflammation is present. Now let's look at a cartoon of what we'll be seeing. Here you can see the synovium is a little bit thickened. We have the cartilage is thinned and fibrillated and jagged with shedding of some as these loose bodies. We have a subchondral cyst that's forming here as fluid is forced into one of the fractures, but the joint is completely mobile. We do not have an ankylosis, and that's going to be relevant when we discuss rheumatoid arthritis. Let's take a look at the radiology, because I think that's very informative. This is sort of a low power view. I wanted to give you a higher power view here. This is obviously looking at our femur and tibia. And you can see here where these two arrows are, we have joint space narrowing. So we've lost cartilage. And at some points, we can actually see where the bone is directly on bone. Now, osteophytes can be a little bit difficult to see, but I think here you can appreciate one there as well as one here. There are some smaller ones here with these arrowheads. What do we see grossly and microscopically? Here is that microscopic image where you can see that fibrillated cartilage. And you can imagine with this fissuring that comes down, this piece could, because of mechanical stress, be shed into the joint space. Here is what the head of that joint looks like. First, for comparison, we can see what healthy cartilage looks like, a nice thick area here. But on this area, it has been completely worn away. This is referred to eburnated bone. And if you can imagine the corresponding bone above that, which is also lacking articular cartilage, you can see why that pressure is going to cause miniature fractures and pain. And because of the lack of the shock absorber, we'll have sclerosis. And then with those fractures and introduction of fluid, these subchondral cysts. So treatment for osteoarthritis is based on pain management. NSAIDs can reduce inflammation, as can intra-articular corticosteroids. Patients may modify their behavior, their activity, so that they're not, for example, running long distances. And weight loss is also sometimes part of the regimen for osteoarthritis. And in severe cases, arthroplasty is performed. Now let's move on to rheumatoid arthritis. So unlike osteoarthritis, which is a biomechanical disorder that then has inflammation as a secondary component, inflammation is front and center in rheumatoid arthritis. It's a chronic autoimmune disorder that primarily attacks the joints, resulting in a non-suppurative, proliferative, and inflammatory arthritis. Now there can be scattered neutrophils, in fact there will be, but it is not the purulent inflammation that you would see, for example, with a gonococcal arthritis. Because of this inflammation, we get articular cartilage destruction, which can lead to joint fusion, something we don't see in osteoarthritis. And rheumatoid arthritis also has an impact outside of the joints. There can be rheumatoid nodules in the skin and lung, and I'll show you the pathology of that shortly. The heart can be affected with pericarditis and accelerated atherosclerosis. So what is the pathogenesis of rheumatoid arthritis? Well, we know that there is an inherited component. About 50% of the risk is inherited and is associated with the HLA-DR4 allele. Similar to what we saw when we talked about celiac disease, we have this HLA type 2 association. And I'll talk about where we think that comes in a moment. So what we see in rheumatoid arthritis is CD4 positive T cells are reacting against a joint antigen. More on that on the next slide. When they are having this response, they're going to do what they do best, secrete cytokines. And the cytokines are going to incite this inflammatory cascade. So interferon gamma is going to activate macrophages as well as synovial cells. Macrophages are going to begin eliciting a lot of cytokines, tumor necrosis factor, IL-1, IL-6, and more, which will recruit and activate lymphocytes, leukocytes, and other cells, and stimulate protease secretion, which is going to lead to our cartilage destruction. Th17 cells are going to elaborate IL-17, recruiting neutrophils and monocytes to the area. So we're calling all these inflammatory cells to this joint. And our activated T cells are going to elaborate rank ligand, which will stimulate osteoclasts, leading to bone resorption. So I talked a little bit here about these joint antigens. What are these joint antigens? So we know that we have serum autoantibodies that are associated with rheumatoid arthritis. And what we believe happens is that we have some sort of proteins in the joint that are modified by citrullination, which is a post-translational modification. And I'll show you what that looks like in a moment. When you get citrullination of these, it modifies these epitopes, creating a neoantigen, which can be recognized by these anti-citrulinated peptide antibodies, or ACPAs, which are seen in about 70% of patients with rheumatoid arthritis. There's another serum autoantibody we can see in rheumatoid arthritis. It's referred to as rheumatoid factor, and that's serum IgM or IgA that binds to the Fc portions of self-IgG, seen in about 80% of patients. And it's thought that perhaps an epitope on citrulinated peptides, such as vinculin, are presented to class 2 HLA-DR4 molecules, which are able to recognize them. Now I'm going to show you some biochemistry, just because you learned it to come to medical school, so why not use it a little bit here? This is a protein chain. This is the peptide amino acid arginine. And citrullination is going to remove this amino group and put on a ketone group. And this is obviously something different. This has now become an amino acid called citrulline, and this is what those anti-citrulinated peptide antibodies will recognize. So let's look at the big picture of what's going on in rheumatoid arthritis. So we have our susceptibility genes, which are going to lead to a failure of tolerance and unregulated lymphocyte activation. As with all of our autoimmune diseases, we have a genetic as well as an environmental component, so let's bring that in. We have some sort of infection that may cause molecular mimicry and recognition now of self-antigens. Smoking can also be involved in modification of peptides. And we get this citrullination of our self-proteins. These two combined together are going to cause a T and B cell response to self-antigens, including those in the joint tissue. So we're going to have Th17 cells, which I mentioned before, Th1, and our plasma cells that are putting out antibodies. We shift over to here, and we see that these cells are going to enter the joint space, and not just the cells, but also immune complexes, stimulating synovial cells, fibroblasts, and chondrocytes to release proteases and cytokines, as well as macrophages being stimulated to release proteases and cytokines. Macrophages are going to elaborate tumor necrosis factor, which is going to recruit lymphocytes, and we're going to have deposition of our immune complexes here. All of this is creating this edematous, inflamed synovium that is referred to as the pannus. Pannus meaning cloth. So it's this very thickened piece of tissue. So this pannus, which has got all these cytokines that are being elaborated, is going to destroy our articular cartilage and can also from there invade into bone. So what are the clinical findings of rheumatoid arthritis? As with most autoimmune diseases, it affects females more than males, and typically will have a non-specific onset with malaise, fatigue, and generalized musculoskeletal pain, which will develop over weeks to months into joint involvement. These individuals will have morning stiffness that does not improve with activity, and the joints that are involved is typically symmetric, beginning with the small joints of the hands and feet, and then in descending order we see involvement of the wrists, ankles, elbows, and knees, as well as the metacarpophalangeal and proximal interphalangeal joints. The joints themselves will be swollen, warm, and painful because, again, they are inflamed. And what you'll see clinically is radial deviation of the wrist with ulnar deviation of the fingers. So like this, and I'll show you an x-ray as well as a clinical image. Something else we'll see will be flexion and hyperextension of the fingers. This is due to that synovitis, which can cause ligament erosion, and at the insertion point of muscles can weaken that attachment so that you get an imbalance in the intrinsic muscles of the hand. Let's take a look at the clinical findings. Here you can see our radial deviation of the wrist, our ulnar deviation of the fingers. Here we have our metacarpophalangeal joints that are involved. They're quite swollen. And then as well the proximal interphalangeal joints. Radiologically, we're going to see again our radial deviation, our ulnar deviation, and we're going to have joint space narrowing. So here and here it appears like just bone on bone. And for those of you who aren't radiologists, I can tell you that here we have a generalized osteopenia. Now, I referred to this flexion hyperextension. There are two terms that are used frequently in conjunction with rheumatoid arthritis, although they are not specific for rheumatoid arthritis. One of them is the boutonniere deformity, which is PIP flexion, which you can see here, and DIP hyperextension. Another deformity we can see in the fingers is a swan neck deformity, where you get hyperextension of the proximal interphalangeal joint, and then joint flexion of the DIP. So you can see that occurs there. Again, not specific for rheumatoid arthritis. So our additional morphologic findings will be on the gross side. When we look at that edema, that synovium, it's going to be thickened and edematous with shaggy villus projections due to a papillary growth from all of this inflammatory cytokines, inflammatory cells, and the proliferation of the synovial cells. Microscopically, we'll see that synovial cell hyperplasia and proliferation, a dense mixed inflammatory infiltrate with T cells, plasma cells, dendritic cells, and macrophages, and it can be so pronounced we even see lymphoid follicles. We're going to have an increased vascularity due to angiogenesis, and we can have a mild fibrinopurulent exudate because there will be some neutrophils involved. Osteoclasts, as I mentioned, are ramped up, so we'll see osteoclast activity of the subchondral bone, which can result in periarticular erosions and subchondral cysts. And then the important finding is this pannus, this thick cloth-like synovium that's edematous and filled with inflammatory cells, granulation tissue, fibroblasts, and neovascularization. And this can erode our articular cartilage as it grows over it. And when that happens, it can grow between the opposing bones, forming initially a fibrous ankylosis, which restricts joint motion, but ultimately it can cause a bony ankylosis or joint fusion. So let's look at a cartoon of that. Here we have our thickened pannus. We have our destruction of the articular cartilage, as well as underlying bone with formation of a subchondral cyst. We have an initial fibrous ankylosis forming here as the bone touches, and it is bridged by the pannus, and then the bony ankylosis as that joint fuses. So here's just a really nice image to bring this home again of what we see in the healthy joint compared to the rheumatoid joint. And this is showing these papillary projections, that shaggy appearance of the synovium. Let's look at another image of that. You can see again this papillary appearance, but on this magnification you can appreciate a little bit better the synovial hyperplasia. And then this population, which I can tell you is plasma cells. How do I know? Let's look higher power. Look at this sea of plasma cells. If you are ever wanting to know what plasma cells look like, here they are, with that eccentric nucleus and little clearing for the Golgi apparatus, where we have this ladybug appearance. And there you can see our synovial hyperplasia. So let's move now beyond the joint into the subcutaneous tissue, perhaps also the lung. This is a rheumatoid nodule, which is a firm, non-tender, round to oval mass, typically found in the subcutaneous tissue of the forearm, elbows, occiput, and lumbosacral area, so areas where there's pressure, and also can be seen in the lung. These are necrotizing granulomas, so to remind you what those are, we have this ring of epithelioid macrophages surrounding this area of necrosis in the center. All right, I'm going to finish up with a table, which I always find useful when I do a compare and contrast, and this is the best way for me to learn, is not learning what one entity is, but how it contrasts and compares to another. So I think this is useful. And then again, these two images that I've shown you several times, now we can do that compare and contrast here. And the main features that you'll notice will be this thickened synovium compared to mildly thickened synovium, as well as this joint fusion, which is what you see in rheumatoid arthritis, not in osteoarthritis. And you'll also appreciate that we see our osteophytes in osteoarthritis, but not in rheumatoid arthritis, because in part there's a different inflammatory milieu. Now I'm going to end with a couple of questions. I think it's important to think about the role of inflammation in osteoarthritis, and then also to look at how the morphologic findings of rheumatoid arthritis reflect its pathogenesis. As always, thank you for your time and attention. I hope you have found this useful. Please send me some comments. Let me know what you liked, what you need more of. Follow me on Twitter. Check out my website. Thank you very much.